So we are continuing with the discussion, and welcoming back my colleagues, Professor Baruch Itzhak, Louise Moist, and Mehmet Ungan. This part of the discussion is going to be a live discussion, and we're going to take some questions from the audience. Baruch, just quickly, while we wait for the question, there is one that I was thinking about. Is there any merit in doing the urinary ACR before EGFR when it comes to diagnosing chronic kidney disease?
You mean to start with the USR or?
Yes.
Well,
Yes.
first of all, in some systems in our colleagues' offices and computers, we can actually see the EGFR automatically. The computers are giving us the results of the EGFR, and sometimes it's easier. It's the first point that we can follow up and see the patient during time. But I think that we should do also the urinary albuminic creatinine ratio in a dipstick test. It's a simple test. It is not complicated, and still it is very important to combine it together with the EGFR. So I believe that we should do it at least once a year in those patients who are in high risk for a CKD, even if they don't have it yet.
Yes, I was just posing a question to Louise. We are aware that the KDIGO 2023 version is due to be released soon, later this year. Are you aware of any updates that we need to be aware of in primary care at all?
Yes. Well, thanks for that question. I just saw the draft review yesterday and sent it around to my clinic. So thankfully, I've had a look at it. I think it reinforces what we talked about, really the importance of screening and making the diagnosis, as we said, particularly the ACR. And again, I alluded to, but in the updated guidelines, which will be released next year, they really are looking at those pillars of care, similar to goal-directed care we saw with heart failure. So the basics in place, as we said, lifestyle, which we heard so elegantly stated, then layering in blood pressure control, ACE, ARBs, particularly in diabetics and with proteinuria. Then consideration for the SGLT2s in both diabetics and non-diabetics. Again, I did list previously those that are relative contraindications, although there is a study currently calling the lifestyle study, I believe, being conducted in Germany that will be looking at those populations not yet studied with SGLT2s, EGFRs below 15, transplant on immunosuppression and on dialysis. Then they look at sort of the finerenone, the non-steroidal mineralocorticoid receptor antagonist. Again, currently that's just indicated for diabetic kidney disease, but there are studies underway looking at it in non-diabetic kidney disease, looking at it in combination with and without an SGLT2 inhibitor, and also a study looking at it in preserved heart failure, as we did see that change. People were excluded that had heart failure in the trials, but they still found a benefit. So those are the studies I'm aware of with finerenone. The GLP-1s are really of interest. The primary outcome trials with kidneys are still to be released, but the secondary analysis of the larger studies, such as SELECT, have shown a decreased rate of decline of EGFR, which I've alluded to before. So I think it is that layering and then broadening the population beyond just diabetic kidney disease to see which of these would be applicable in non-diabetic kidney disease. So that's what I've read so far. Thank you.
Thank you very much. You are ahead of the game, Louise. Thank you so much for the update. Mehmet,
I was reading ahead.
Mehmet, just a quick question. Which cardiovascular outcomes should we be worried about in people with chronic kidney disease? And how should we manage these outcomes in primary care?
Actually, it is. I think in during the video section, we were just discussing about the once you have damage in the kidneys, that means that it should be also in your other vessels, not only on the peripheric vessels, but also in the cardiovascular system, especially. I think that was a very good message of Louise, saying that if you have a leakage like a car, a leakage of oil, then that means that there is other problems in the other part of the body, and especially the vascular system. So I would first be really worried about the coronary heart disease immediately. And during our checks, I think it would be nice to focus on the, especially in the coronary heart, and also some kind of insufficiencies in the cardiac system. That's the summary for me.
Yeah, sometimes it's a predictor. It's a predictor for cardiac disease, the proteinuria, absolutely, the microalbuminuria, and you are right.
That's a great summary. So just quickly, Louise, just coming back to you again, there is a question of presence or absence of diabetes when it comes to using an SGLT2 inhibitor. From the presentation, it looks to me like that shouldn't make a difference. These drugs work very well in patients with and without diabetes. Would you concur with that? Simple messaging for primary care.
Thank you. Absolutely slam dunk for diabetes, proteinuria, non-proteinuria. In non-diabetic kidney disease, with the exception, as I mentioned, polycystic kidney disease, the high dose immunosuppression, instrumentation perhaps, and type 1 diabetes, it can be considered if there is proteinuria, and defined by that, I think in your units is around 300, and in the SI is 30. However, the EMPA kidney did include people that were both diabetic and non-diabetic that did not have protein in their urine. But the only group they included that did not have protein in the urine was if the EGFR was less than 45. So that's the stipulation of CKD without proteinuria. If the EGFR is less than 45, the EMPA kidney, which was the only one that included the non, did show that it reduced the rate of decline of EGFR. And I alluded to that before in the presentation of that sort of 1 to 3 mils kind of expected. It did reduce that rate of decline. So important, that's the evidence we have currently. So in non-diabetic kidney disease without proteinuria, there is evidence to support SGLT2 inhibitor with EGFRs below 45. In part, that was because the study's 3 years, and you wouldn't expect to see much decline in someone with an EGFR above 45 without protein, to all the points you've raised as being the proteinuria really being an accelerator of risk. So partly it's we just don't know above 45, but below 45, you can enroll CKD without proteinuria. Otherwise, with proteinuria, other than the exclusions, it's indicated for a broad population of non-diabetic CKD. Thank you.
I've got another question here. Involving patients in their own care, what patient engagement strategies can you use in primary care to improve kidney outcomes? And that is to my primary care colleagues, Mehmet and Baruch. What strategies would you use to engage primary care teams to improve kidney outcomes?
Yeah, that is a really very good question, and also it's a matter of the non-communicable diseases as a whole. I mean, not only the kidney, but it's related with the life. They usually call it a therapeutic patient education. I think that there should be kind of activities routinely on behalf of a general practitioner in the primary care, just trying to help our patients and the audience and the normal population also to have the lifestyle modifications and interventions sometimes when they have the disease. But before they have the disease, I think that will be very good if we can just increase the health literacy and the therapeutic patient education activities just to empower our patients and the population. This is how we look at as a public health, and the WHO, World Health Organization, is also preparing such kind of guidelines, which we, as the primary care physicians, and our team can have a benefit for that. I think those are not rocket science. Those are all depending on the really healthy lifestyle, which is every JP has kind of good knowledge as I see. But maybe we can just add a few things which are new developments other than the therapeutic pharmaceutical preparates. Then I think we can just talk about healthy diet and exercise and good lifestyle, enough sleep, and stress, dealing with the stress in a right way, and also I think enough fluid intake and restriction, not maybe restriction, but not using salt, additional salt in Mediterranean countries, especially it's very important because, once you start to eat, you just put the salt in everywhere there is still salt in the Mediterranean region. Those kind of measures should be which I thought immediately.
And
Yeah.
Sam, if I
Yeah.
may add, to
Yeah.
this point, this is a very important point. The engagement of our patients is very important to the process. So just to give you, for example, a practical tip, how I use this engagement, usually if I see a reduced EGFR, I'm saying to the patient in his language, look, your kidneys are now a little bit damaged. They are working only 50%, 60%. And he is very surprised. He even doesn't know it. And he said to me, Doctor, what can we do together? How can we approach together the engagement and to rescue my kidneys? Then I consult him with some new, maybe to give him new medication, but I consult him also to go to a dietitian and to have also the protein restriction in his food and all those other processes in lifestyle. So speaking with the patients in their language and explain them in their language helps very much.
Thank you very much. There is another question here which I will direct to Louise. The question says, can compromised immunity result or worsen chronic kidney disease in type 1 diabetes?
Thank you for that question. And it's a brilliant question. I might even expand it. We're really seeing more and more involving the immune system. I heard a mention of stress as one of the 8 pillars of health, and who knows what all that stress is. But we are seeing more inflammatory mediators that are part of our immune system, the TNA, the IL-6, TR2s, all increased with the kidney disease, as we see with other vascular disease. And you will be starting to see more evidence about blocking the immune system in kidney disease in general, not just type 1. So you'll see some of these MABs, canacluzumab, I have to practice saying these still, colchicine, we'll see coming up after some of the other vascular trials as that sort of having an anti-inflammatory. So this is a key area. It didn't make the new guidelines that I read, but certainly the evidence is growing in vascular disease of blocking this inflammation, which is driven by the immune system. And we'll be starting to see some expansion of medications into that area, including all of these biologics as we come. The studies are showing it reduces the inflammatory markers and early indicators that it reduces disease. So I think keep an eye on things like colchicine, some of these newer MABs will be coming out for CKD over the next 5 years. I'd say it's really accelerating. So brilliant question. And again, back to those big pillars of health that we talk about, the blood pressure, diabetes, etc. Stress, as we said, is one of those pillars, as well as sleep. So I think sometimes we talk to people about this broadly, and maybe one is more pertinent to them at that time, but definitely an important thing to watch for in the literature and in the upcoming guidelines after this year. Thank you.
Thank you. There's still a lot of questions, but I don't know if we've got time to squeeze in another one. There's just a question here again that is on young people, type 1, causes of chronic kidney disease in the young patients under the age of 20. Do we have any ideas on this?
I'll take that one. I did see that before, so thank you. I think this is a brilliant question. A couple things. I would suggest that certainly a good diet history and the use of creatine as a protein supplement. So make sure that you've reviewed all of those things as what they're doing. We do see that this person does have a raised BMI, and we know that
Yes.
obesity is an independent risk factor for kidney disease. So it is kind of all brought together with diabetes and hypertension, but independently, just obesity does increase that risk. However, creatinine is not a good marker of kidney disease in the extremes of weight, either the lower weight or the higher weight. And I'm not sure what the prevalence of use is of cystatin C, which is not based on muscle mass, but in those extremes of weight, it is recommended to do a cystatin C, and this is in the KDIGO guidelines. So if they're at those extremes of weight, or you're right in that 60 mark, you could validate it by doing a cystatin C eGFR. So they measure the cystatin C independent of muscle mass. So I would start with those two questions. Other than that, a very good family history, looking for genetic causes such as Alports, looking for congenital causes, although you said the ultrasound was normal. In women, we do see some reflux nephropathy that didn't get picked up. So ask about history of UTIs when they were younger and seeing of any story there. There might be some scarring that's not yet evident on the ultrasound that you would see. Again, review medications, a lot of NSAID use in this population. Again, other illicit drugs that may be brought forward with that. I think very important to do that, to look at it. So again, look at, are you using the right marker? Consider a cystatin C if at extremes of weight. A very good family history, doing a good childhood history. I mean, I don't know this person, but if they've had any pregnancies, that would also be helpful. Medications, and then again, screening for other things. But I would definitely start with those basics before I started into a whole SLE or other workup without any other symptoms. Thank you.
Louise, what is the most common cause you see in those youngest people with chronic kidney disease?
Yeah, I would say it is either congenital, that when you do the ultrasound, there is a smaller kidney or an absent kidney. So we're really running on one engine, although the eGFR should be good. There might be some stress. Use of creatine as a protein supplement or high protein diets that these younger people are often doing. Some hereditary disease that we haven't picked up yet, that there is a family history. We have a high immigration population, as you do, so it's sometimes really hard to get that. And then obesity independent of itself and just their lifestyle. I think we're seeing higher risk of kidney stones in very young people, higher risk of obesity, higher rates of hypertension. So I think we're just moving that curve. Instead of seeing things in their 40s, unfortunately, we're starting to see them earlier.
Thank you.
Thank you very much. So I think we're running behind time now. Baruch, I'll hand over to you now to do the concluding statement.
Yes,
please.
thank you very much. Thank you very much. So we are actually approaching to the end of our journey, and some points I would like to have for our summary. What are the take-home messages? So first of all, early management with lifestyle intervention and appropriate pharmacological treatment can prevent renal deterioration. RAS inhibitors, SGLT2 inhibitors, and MRAs have a crucial role in addressing these conditions together or on their own. Tools such as the ICN KDIGO one-pager can be used to provide guidance on identification and intervention for CKD in primary care. And I will present now the one-pager toolkit in our next slide. You see, this is a very practical and helpful a toolkit, one pager that you can use it in your clinics to identify, to stratify, and to treat the patients with CKD. This kind of toolkit is endorsed by 4 big organizations: the International Society of Nephrology, the KDIGO, the WONCA Europe, and the Primary Care Diabetes Europe. So please use these toolkits. It's very easy and portable. I would like to remind you our next activities on CKD for primary care management. Our independent educational program will provide decision support and educational tools to guide primary care practitioners in a real-world clinical context. Interactive simulated patient-doctor set scenario are enhanced with expert-led discussion and commentary and supplement of those, and will be coming soon. Please be in contact and follow up our new activities. And last but not least, I would like to thank today our faculty members that worked hard to convince you that we have to treat early as possible the CKD patients in our clinics. So this is Professor Samuel Seidu. He is a professor of primary care, diabetes and cardiometabolic medicine, University of Leicester, United Kingdom. Louise Moist, a professor of medicine and epidemiology, London Health Science Centre, Canada, and Professor Mehmet Ungan, professor family physician in Ankara University, Turkey, and myself, Baruch Itzhak, who am a diabetologist and specialist in family medicine at the Clalit Health Services Technion Faculty of Medicine, Haifa, Israel. Thank you again, all of you, and hope to see you soon. Good luck.